Hello, and thank you for joining us today. Results of recent clinical trials in lung cancer have led us to a sea change in thoracic oncology as we persist in exploring new therapeutic targets and evaluating new ways to sequence and combine novel immuno-oncology agents. In this OncLive peer exchange discussion, key updates and practice-changing data for advanced non-small cell lung cancer, I'm joined by an international panel of experts in lung cancer clinical research. Today we will discuss the key studies that will impact the way you treat your patients, including updates from the 2018 World Conference on Lung Cancer and the ESMO annual meeting. I am Mark Sosinski, Executive Medical Director of the Florida Hospital Cancer Institute in Orlando, Florida. Participating today on our distinguished panel are Dr. Maximilian Hochmeier of the Respiratory Oncology Unit at Otto Wagner Hospital in Vienna, Austria, Dr. Leora Horn, Ingram Associate Professor at Vanderbilt University Medical School in Nashville, Tennessee, Dr. Suresh Seenan, Professor of Radiation Oncology at the VU University Medical Center in Amsterdam, Netherlands, and Dr. Thomas Stinchcomb, Professor of Medicine and member of the Duke Cancer Institute in Durham, North Carolina. I look forward to a great discussion. Let's begin. Let's start. Tom, I'm going to ask you, 2 years ago, actually at the ESMO meeting, we saw the results of KEYNOTE-024, which really changed practice. I wonder if you could just kind of summarize that data.
So KEYNOTE-024 is, I think, one of the landmark trials, like you said. It identified patients with PD-L1 tumor proportion scores greater than 50% and then randomized them to pembrolizumab or a platinum doublet and resulted in a statistically significant improvement in progression-free survival, overall survival, as well as response. And I think on longer follow-up, the median survival on the pembrolizumab arm is about 30 months. And I think that this sets the context for all the subsequent trials and still remains a single-agent pembrolizumab remains my preferred therapy for the high tumor proportion score patients.
I mean, I think the last update we had had a median survival of 30 months in that greater than 50% treated with pembrolizumab. So we haven't seen those sorts of numbers in lung cancer before.
No.
Tell me, are there patients in that category of greater than 50% in which you would use chemo in addition to pembrolizumab? Because obviously they were included in a number of the other studies that we'll talk about in a moment.
So I sort of look at the PD-L1 score in the context of the clinical context, and there are some patients who have a PD-L1 score greater than 50%, but maybe they're very symptomatic, borderline performance status, and you get a sense that you only have one chance to intervene in the disease. Right. And I think those are the ones I'm more inclined to use the chemo-immunotherapy combination up front. Right. But if they're sort of asymptomatic, good performance status, I tend to use single-agent immunotherapy.
Because the one thing from the analysis of 024 and KEYNOTE-189, which we'll get to in a moment, you know, the one-year survival seems to be about the same, but the response rate was about 20% higher with the addition of chemotherapy. So for those symptomatic patients, that's kind of my strategy.